student in his endovascular fellowship, specializing in vascular neurosurgery. So Kurt, welcome back to Grand Rounds as a presenter.
Thanks. Yeah, please let me know if I'm not coming through at any particular point. So far, so good?
Yeah, looks good.
Okay, yeah, just let me know. All right, so yeah, I wanted to present on this topic because, you know, as the chief resident, first case with Dr. Shrivastava, you know, reviewing the anatomy and getting to know everything really well and before the case. And then the first question he asks on the day of the surgery on a MVD for trigeminal neuralgia is who wrote the first paper and who described this. And I was completely embarrassed because I had no clue. So this is really, as the title of the talk says, Intraoperative Monitoring for Microvascular Decompression, or How to Survive the OR with Dr. Shrivastava, and impress everyone else by knowing not only the anatomy and the but also the neurophysiology behind a lot of this. Still coming through okay? Just want to make sure. Okay, thank you. And yeah, this is more of a talk for the juniors and the you know, the senior residents to test their knowledge. I know it's been about an hour already of torture, but I think, you know, a little bit longer is going to be okay. So this is more of this is like a trivia question more than anything else, and is mostly for someone like Travis because he tends to know stuff like this. But the answer to that question, who initially described this, is someone named Peter Janetta, and he really wrote the initial papers describing the pathology and also the surgical management of microvascular decompression for trigeminal neuralgia. And this is a picture from one of his papers. The next real landmark paper on this topic is actually by one of our own, Dr. Natick, and he described the comparing the anatomy, the gross anatomy with the MRI, looking at different the microanatomy of the trigeminal nerve and the relationship with the vascular compression causing trigeminal neuralgia. So this is a anatomical study from the paper. And first I'll have Noah, can you first describe what we're looking at here, this right and left, what exactly is going on?
Sure, so it looks like cadaveric sections through the middle ear. We can see that looks like the large black arrow is the sensory root of 8. The white arrows, I think one is pointing to a blood vessel, so that's going to be the SCA.
Yep.
And I think superior, the nerve, I think, is the motor root of as well.
Yeah, let me take a step back because I didn't describe it very well, but yeah, so that you're absolutely right. You actually got the correct answers. That there's actually 3 segments to the nerve. There's the sensory root, and there's the inferior and superior motor roots. And so you nailed it. But that is the overall point of this part of the talk, is that this distribution of the anatomy is very important to acknowledge during the procedure of a microvascular decompression. And this is, like you said, a sagittal view, and it's looking mostly at not necessarily the inner ear, but this is MEC, which is Meckel's cave, and you see the nerve traveling in that direction, anterior posteriorly. And how about this one? What orientation is this in?
So again, cadaveric section, it appears to be an axial, just straight through, I think.
It's actually a coronal. The pons, this is third ventricle, and these are the nerves coming out at us. Here's the basilar artery. Okay, so then this large white arrow would be
that large white. I think it's still the sensory rootlet.
Yeah, because it's the biggest. Yep, and then you have the smaller rootlets.
Yeah,
the motor. Yeah,
superior motor.
Yeah, tough. These are tough questions, so thank you for participating. This all goes to compare to these studies, which is some things we're way more familiar with. And to kind of summarize what you were telling me before, is this sensory rootlet. This is the same sagittal view going anterior posterior, and it's much bigger than the two smaller motor rootlets. And this V obviously means venous structure. And then here in the coronal, you see a large sensory rootlet and the two motor rootlets as well, and then the relationship to the SCA on top of that. So overall, this is another question that Dr. Srivastava asked me, and I bungled initially. There's specific names, like traditional names for these are Portio major, Portio minor. And as you can assume, the major is the sensory rootlet, minor is the motor rootlet. And when we look at it like this in the textbook, the sensory rootlet is going to be inferior. And the motor rootlet's obviously going to be a little more cranial in relation. And you'll keep that in mind when we look at the anatomical views, because it's flipped. When you're doing the approach for surgery, the sensory rootlet's going to be in front of you. So it's going to be the first part of the nerve that you visualize. So here's a little bit of a different schematic, and just to look at the relationship of the vessels and the nerve. And there are a couple of things that really disturb me about these pictures. Brandon, what this is a tough question. Maybe I'll bump it up to Abhi. What are some things that disturb me about these two, as a vascular person specifically? How about this one here? What do I take offense with?
Let's see. Where's that part? I don't really see an icon.
That's right.
There's no icon there.
Yeah, it's not no tricks. Yep, I don't. They didn't really draw it that well, so I'm a little offended about that. But to cut to the choice, the thing that really disturbs me with this one is that normally the SCA comes above the nerve, and all their variations obviously, but that's typically what I've seen. And Halima, what's the typical compression pattern for trigeminal neuralgia and hemifacial spasm? What are the arteries, and how do they compress the nerve, and how is that the pain generator? Describe that a little bit for me.
So for trigeminal neuralgia, the offending vessel mostly is the SCA, and it basically is in either the SCA or one of its branches is directly in contact with the nerve, mostly at the root entry zone. And then for hemifacial spasm, it's AICA, the most common offending vessel, but obviously it could be venous compression as well, and it could, like, in order of, like, for trigeminal neuralgia, it could be SCA followed by AICA followed by even pica sometimes, or even the vertebrovascular junction.
Yeah, exactly right. Thank you. Yep. All right, Halima. So this is kind of just a background for what we're getting into the meat of the talk, but I think it's helpful to do these once in a while to describe the setup for a procedure. So say you're booking the procedure and you are, or you're in the boards, you're describing the procedure. Can you take me through the things you're going to need for the operating room and how to set up the room and then position the patient? Halima.
To start with what we are going to need in the room, so you're going to need Mayfield in terms of instruments. We will need microvascular instruments, and it's a MBD, so we're going to need Teflon. We will need microscope in the room. We'll need intraoperative monitoring, in which we will use the NIMS machine as well as the SSCPs, ENGs, and bears. Anesthesia considerations, we would have the anesthesia team have the patient, have a bite block in, no paralysis.
Great. Excellent. I would,
we would need the Doppler.
Yep.
Mm-hmm.
Yeah, keep going. And then positioning and setting up the patient.
So in terms of positioning, we want we start with the pinning. So normally we do 2 pins on in the back of the head from the contralateral side, and then one pin in the lateral forehead around the mid-pupillary line. We want the head turn all the way towards the contralateral side and the vertex down. The shoulder should be like all the way to the edge of the bed, and then we will we have to burrito the patient with appropriate padding, and then we will have all of our like the facial nerve monitoring and bears and nerve monitoring.
Excellent job. Yep. You described it very well. So I saw this from a paper on microvascular decompression, and I was appalled by the positioning. I think we are trained here to be very particular in how we position. I think both Dr. Srivastav and Dr. Pedersen would take offense with this in a couple different ways. So Matt, what do you see wrong here, in specifically how Halima eloquently described the way we position it? How would you change some of these things?
Yeah, I think that in general, the head positioning is not optimized. We're going to be operating very laterally, it looks like, from this position. So I would turn his head more if possible. I would also try to get the vertex down a little bit. I mean, I think you really sort of want the mastoid to be the highest part of the head if possible. Otherwise,
let's see. Yep.
Pin might be a little close. The shave, I don't think the shave is sort of an odd shave. It's sort of like a aggressive haircut. That's not, I don't think, optimal for the incision. I think there's sort of hair close to the top where you have to go, instead of too much hair shaved sort of more towards the midline. And I don't see the monitoring lines in yet, which maybe those are going to be put in later.
Yeah, it's pretty good. I think you hit most of the ones that I thought. So the head definitely needs to be turned almost like towards the nose as much as possible. The nose almost towards the ground. Vertex down, definitely. And bringing the shoulder uncomfortably off the bed is what I would say. And as much as I do it, Dr. Srivastava usually wants more. Patients almost falling off, but I think it's helpful when you're extending your arms and trying to reach in at the depths of the skull base. The pinning, I would say, take point this here. I think usually I try to do the ipsilateral mid-pupillary line, try to get it, as close to the hairline. And then down here, sometimes, this you can get away with this positioning, but if you put them horizontal to the ground, you get a little more space with your skin incision. So that's something to consider as well. And intraoperative monitoring, obviously those need to be in place. And then the shave is awful. I think this is something we learn pretty strictly to be as minimal as possible. And this guy kind of looks like the Tiger King almost with the haircut. So I think to just be as minimal as possible is important. So overall, I think Dr. Pedersen talked about this a little bit earlier, but in general, we use the heads-up display to look at the transverse sigmoid junction, but you can also estimate it looking at the transverse, estimating between the rutozygoma and the inion, and painting that transverse line. And then for the sigmoid, you can kind of feel the occipitomastoid groove, and that's generally where it is. And then incision, I like to do about 2 finger breaths behind the ear in kind of this curvilinear fashion. And you definitely don't need to be this far posterior, but just to show that your incision should really center on this silver dollar-sized craniectomy at the transverse sigmoid junction. And typically, you take a little bit more bone down here. It's not a perfect circle, so you're able to get down and skeletonize the sigmoid sinus a little bit. And then, So the question is, Alex Schuper, is this the left or the right side after the craniectomy? So that, yep, exactly. And what makes you say that?
A couple of things: the orientation of the cerebellum, the cranial nerves, and then the orientation of the sinus as well. Exactly.
So that's one way to get a lot of intraoperative picture questions correct, is by looking at the petrous bone and the tentorium, and the petrosal vein going kind of into that angle here, and then you're right, the nerves angling up towards the bone in this picture. The sinus, as you said, the transverse sigmoid sinus is here, and then also, Alex, what is this diagram here? This kind of goopy stuff on the side.
That's supposed to be bone wax.
Yeah, I assume so for the mastoid air cells.
For all the mastoid air cells.
Right. So I think, you know, a few of the juniors, I may have proselytized this when I'm doing cases with them, but there's a couple of reasons when I'm skeletonizing the sinus with the drill, how I know I'm getting close. Alex, I think I've done a couple with you. Do you know what I tend to say? Like, how do I know I'm getting close to sinus if I'm not sure? What kind of things what kind of hints can you look out for?
I think besides using initially navigation, as you know, sometimes it can be off a couple millimeters with navigation. Some hints that I've learned from you are when we start to get some venous ooze, over like epidural venous ooze, that tends to be a hint that we're at least getting close. Additionally, we can feel with like a Penfield 1 or Penfield 4, we can feel the dura start to tent up as we're approaching the sinus, so that can be another hint. These are two that I know I've learned from you.
And then what do I use to confirm?
Sorry, yeah, we could definitely use the Doppler as well.
Yeah.
To listen to the sinus.
Yep, I like to, so you're exactly right. So you kind of get a sense initially, there's a little bit of venous oozing, kind of purple, just non-specific. And sometimes you need some Surgiflow to pack it off temporarily. Then you see the dura color change. It'll become a little more purple, and you can see it. So you use your different senses here, and definitely use navigation to give us kind of outline. And then when you're getting closer and you kind of get the sense like you're over it, then you can use the Doppler. You can kind of angle it underneath at first to see if you're going the general direction. And then once you're close, you can put it directly perpendicular to the dura and confirm. And usually it's very purple and obvious at that point. Yeah, so I like to kind of use.
If I can just interrupt you for 1 second,
Yeah.
I just wanted you to point out one thing that's in this picture, which really shows the nice transition from cancellous bone to cortical bone right before you get to the dura. So that's another thing when you're mentioning with your drill, that you feel the difference in the bone when you're getting close to the dura, whether it's over sinus or just native dura.
Yeah, absolutely. Totally agree. And as Alex said, a lot of times it will, the bone at that point goes up over it transitions from kind of sloping down to sloping up. So you have to be careful when you're undermining that, because the sinus can be tucked underneath that bony lip. So when you get to that cortical bone, be careful and strip it with a double ender. All right, so now we're down under the microscope, and Brandon, obviously this is the same orientation here on the left side. So there are a couple nerves here. One you're going to see right away as you're dissecting and you're retracting the cerebellum a little bit, and that's this one kind of in the foreground, and there's one a little bit deeper. Can you tell me which one is which?
It's on the left side of the screen. That's going to be the 7-8 complex, and then more towards the right is going to be 5.
Yep. What is this structure back here? This kind of yellowish structure.
That looks like the ventral surface of pons.
Yeah, exactly. So it's helpful to remember there's a couple different ways to distinguish these nerves. I think for me, 7-8 is usually the first one that comes into view. It's going to be closer to you when you're retracting the cerebellum. So usually stumble upon that first, and it's a little bit obviously caudal in orientation. And then the 5th nerve is going to be it's going to be deeper in the field. It's going to be kind of laying on the brainstem initially, and it's going to be going away from you into the distal skull. Whereas 7-8 is going to be more, I guess, perpendicular, or parallel to your field, and 5 is going to be going away from you. So Brandon, what side is this? This is from our case.
So this looks
Brandon?
like the, this looks like it's the right, you can see, I believe that's the 7-8 complex on the right side of the screen. And then you're
Yep.
looking towards 5, which is going to be to the left of the 7-8 complex. So it's a right-sided approach.
Great, perfect. And yeah, how do I know that this was the case with Dr. Shrivastava and not Dr. Pedersen? Alex, you know?
There's no heads-up display.
Yeah, I wasn't thinking that, but yeah, potentially. I was thinking more that Dr. Shrivastava usually leaves the petrosal vein intact, and Dr. Pedersen typically sacrifices that, but I think either way is appropriate. So yeah, Helium, or I guess Alex, since you're there and probably unmuted, what is this here and what's going on in this picture? And this is for it's a trigeminal neuralgia case.
So it looks like a stimulator, nerve stimulator.
Yep. And why would he be doing that for trigeminal neuralgia? Think about this is tying back into the first couple slides. Why would he be stimulating that part of the nerve?
As to differentiate between the sensory motor branches.
Is Kurt frozen? I think we lost his.
Yes.
Kurt, if you can hear us, can you sign in again?
I can jump in just for a few minutes just to illustrate that picture. So
There you are, Kurt.
Oh, good.
Yeah, we lost you for a second.
Yeah, sorry, I'm on the guest Wi-Fi, so I must have exceeded my time. Sorry. You can keep going. I can wait.
No, I was just going to say, obviously, this is done for illustrative purposes. This is not always needed, but go ahead.
Right. Yeah. So I think in this particular case, we were intending to do a rhizotomy, so we wanted to dissect that out. And so here's a quick illustration of that process. So dissecting out the motor root and then rhizotomizing the sensory bundle specifically. And so I think this is kind of the take home point for this part of the talk is, identifying that there are two parts to the nerve. And again, this will save you down the road from getting questions wrong when Dr. Shrivastava asks. Okay, so now this is getting to the namesake of the talk, looking at intraoperative monitoring for microvascular decompression. I think there's two major modalities we use depending on the surgery performed. And so the first one would be brainstem auditory evoked potentials. So this is what our intraoperative monitoring colleagues will see when they're looking at the bears, and a lot of different waveforms, and we'll go through quickly on how it's produced. Just for a quick review, I'd like to go through this a little bit, and I don't really like doing it myself, so I'll have one of the interns do it. Maybe Noah, can you just describe this a little bit? Talk about how sound gets from your outer ear into the brain, and let's start with this part, which is just the getting to the cochlear nerve. You can describe the way the sound wave gets there.
Sure. So big picture is sound is basically a conversion of a mechanical signal into a chemical signal. So the sound waves vibrate the tympanic membrane, and that then oscillates the malleus, the incus, and the stapes, which then vibrates the endolymph, and then that essentially creates a conversion of that mechanical signal into a chemical signal that travels in the cochlear nerve.
Yeah, exactly. So, and one other to build on it a little bit is a specific question I remember from my boards in terms of the varying frequencies and pitches. So closer, so that the higher pitch noises will stimulate the hair cells closer or more proximal, whereas distally is going to be lower pitch. That's important to remember. And then the last thing that's not labeled here, Noah, what is this right here?
Station 2, I believe.
Yep, right. Okay, good. All right, so let's take it a little more detail here. That's kind of the overview. These parts are what I would consider kind of the structures. So the modiolus is the bony axis that the cochlea turns around. The helicotrema is what, Brandon? What's specific about this?
I believe that's you can get some vestibular components as well.
I didn't hear that, but it's probably my internet. Okay, so let's look at these spaces here. Can you tell me about what are they called here? What's this one?
So that one, yeah, that one where your mouse is, that's the scala vestibuli.
Mm-hmm. Yep. Okay. Sorry, I gave it away. But there's scala vestibula, scala tympani, scala media, and if we go back here, so the sound travels through this scala vestibuli and vibrates the tectorial membrane right here, and that's described here. So I gave it away again. The tectorial membrane is this part here. We have Reister's membrane. We have the basilar membrane here, and we'll zoom it up one more here. Just go into a little more detail about how it works. But again, the Reister's membrane, and then the hair cells here, and those are what's vibrating and providing that electrical stimulus to the cochlear nerve. All right, Brandon, we're gonna now talk about the orders of the neurons here. So can you tell me what each of these dots are as the information travels from the vestibular, the cochlear nerve, to these dots? Can you do red, purple, green, and pink here?
So
first.
That is, first is going to be the cochlear nucleus.
Yep. And then the purple?
Purple is going to be the superior olive, or the olivary nucleus. Yep.
Mm-hmm.
Green is going to be inferior colliculus. And then it'll go to thalamus and the medial genicular body.
Great. Yeah, awesome.
Project to the auditory cortex.
Yep, absolutely. The only additional thing to add here is this pathway is the lateral lemniscus, and to note that there is decussation of fibers to the olivary nucleus here at this stage here, and so you get bilateral information. All right, Abi, can you tell me 1, 2, 3, 4 here? And I gave you a hint. This is the this is the bony structure, the internal auditory meatus. Anterior is here, inferior is here. So tell me about this anatomy. 1, 2, 3, 4.
All right. Yep. So 1, 2, 3, 4. You can have so the anterior, superior one would be facial.
Yep.
2 would be the posterior superior, would be superior vestibular. 3 would be inferior vestibular, and then 4 would be cochlear.
Great. And then these anatomical landmarks here, these two.
So that's the vertical crest, also known as the Bill's bar, and the second one is horizontal crest.
Yeah, very good. Okay. And so here is again the description.
And was that the right or the left? Was that the right or the left? I see.
That's the left.
Is it the right or the left? And how?
It's the left.
Wait.
Well, are you looking from lateral or are you looking from medial? That's going to determine whether that's the right or the left.
So if you're looking from lateral, you would be able to see this. this structure. If it's the left, if you look from medial, it'd be the other way around.
That's correct. And you think you'd be seeing it this way if you're looking from lateral?
No.
No. So therefore,
No. Yeah.
it's the
So
right.
you're looking from medial, so this would be the right. Yeah.
Good. Okay. Well done.
Great. So this is just a better, I think, a better pictorial representation of how Brandon elegantly described the orders of the neurons here. I'm not going to go through it again, but this is important because this is how we're going to generate the bears. And so each of those waves will represent a different area, anatomical area of the pathway, the auditory pathway. So I'll go through it because I think we're running low on time. So the first wave here, and there's 7 waves in general. First wave is going to be the nerve, the acoustic nerve. The wave 2 will be the cochlear nuclei here. Wave 3 will be the superior olivary complex. The wave 4 will be the lateral lemniscus, so this portion here. Wave 5 will be inferior colliculus there, and then wave 6 will be medial geniculate body, the thalamus, and then 7 will be the cortex. Typically, and so here's the interpretation, when we're looking at the bears, we compare it to baseline preoperative, or like as we're starting the procedure. There are different ways of looking at it, including the intervals between wave 1 and 5, 1 and 3, or 3 and 5. But typically what we use most is looking at wave 5 and looking at a 50% decrease in amplitude or a 1 millisecond increase in latency. So what that means is decrease in amplitude that way of 50% or increasing latency, meaning it's being delayed by 1 millisecond. So that's typically when we're alerted for a potential issue. So wave 1 can also be impacted so obviously wave 1 going back to the cochlear nerve, this could indicate ischemia of the nerve. So any issues with Icahn or labyrinthine artery. So in this particular case, there is stretch on the nerve. So you see in number 1, you see a blunting or decrease in amplitude of wave 1 here. And then after giving papaverin and saline irrigation, you can see that it's come back at number 2. So these are a couple of cases that I'll go through quickly. Patient A was a 70-year-old lady with peripheral hearing loss. So you can see that all the waves are pretty much blunted. But however, when they increased the stimulation decibel, you can see that there are that the waves become present again at increased stimulation, and the latency of wave 5 is still decreased compared to the previous. So improvement with increased decibel and peripheral hearing loss. This patient was a younger patient with the 4th ventricular tumor, so the wave 5 was blunted, and these intervals are also elongated somewhat, and an increase in the decibels increased the amplitude, but the delay in latency is still present. So obviously a different pathology, not going to be improved by increasing the decibel level. And this patient is a patient with an acoustic, with a vestibular schwannoma. And so Matt, can you tell me which side do you think this vestibular schwannoma was? This is the left side, this is the right side. Which side would you think has the tumor at baseline?
The right bears here look more like the normal diagram you showed in the previous slides. I think the left one looks like maybe it's a little blunted and prolonged from 1 to 5. So I think probably left-sided.
Yep, you're right. This is left-sided schwannoma. I think the point here is to look at the interval and see the decrease or increase in latency of especially wave 5. So this is an interesting case just to see how things change during the procedure. So A would be baseline. You see the wave, you see wave 5 very well. B is when the surgeons began to retract the cerebellum, and you see blunting of wave 5. As you go down, you see it, pretty significantly diminished here, increase the latency and decrease the amplitude. And then D, they released retraction on the cerebellum. And so you start to see it come back a little bit. And then by the end, E, you see that wave 5 coming back and decreasing latency and increasing the amplitude again. All right, so this is kind of a summary slide looking at it again. Obviously, I'll share the slides and you can use this for future reference, but really we intraoperatively look at wave 5 and just see, like I said, 50% decrease in amplitude and a 1 millisecond increase in latency will give you is usually the threshold to be concerned. So facial nerve monitoring for hemifacial spasm cases for microvascular decompression. I'm not going to go through this. I think again, I'm almost out of time, so
save that for another day.
Yeah, just really quickly to get to the point. Different branches of the facial nerve. Looking at lateral spread. So lateral spread is a very important part of the hemifacial spasm cases. We look at EMG of the orbicularis oculi and the orbicularis oris muscles, and lateral spread response is stimulation of one of the branches producing a response in another branch, and that's pathological and typical of hemifacial spasm. So, for example, the stimulation of the orbicularis oculi will cause a electrographic response in a different muscle group. So here's what it looks like electrographically when the orbicularis oculi muscle is stimulated. Preoperatively in a hemifacial spasm case, you'll see it. We can see a response in that muscle, in the orbicularis oris. However, after the procedure, after mobilization and protection, then that response is gone. So there is, and this is again by Dr. Janetta, there's a good prognostic factor once the lateral spread is decreased after decompression. And this is a more recent paper from 2019 looking at the cure rates after microvascular decompression for hemifacial spasm, looking specifically at lateral spread. Disappearance of lateral spread in 61 patients, 59 had a long-term cure, whereas if there were no change in the lateral spread, really, a lesser, while there are fewer, it's less likely to be predictive of a good outcome. So that was a lot, but thank you for bearing with me, and move on to the next topic. Thank you.
Raj, you have any comments? That was a really beautiful talk.
Yeah, fantastic job, Kurt. I think that was a nice summary. I think, there's several comments we can make, and I think it's a fascinating area for me just from the brainstem physiology as well. So to go back with trigeminal neuralgia, I believe that what we're seeing is epiphenomenon. Clearly there is a compression that we know, and I think that is part of the picture, in my opinion. I think there's probably other factors that are related to brainstem physiology, to the very distribution of the thalamic projections, just like Kurt outlined. And some of the studies we're doing with 7T starting to look at this kind of diffusion pathways, and we're seeing abnormalities which are related. We don't have a direct correlation yet, but clearly, anecdotally, we all know that we see patients who have compression on MRI imaging yet don't have pain. So there's more to it, I believe, than just the physiologic compression. I think there's a select population. I think there's white matter changes that occur. I think that there's probably different projections in the thalamocortical sensory distribution. Actually, that's part of it as well, because MS, for those of you who know, can also mimic trigeminal neuralgia and not have compression. So it's an interesting area to study, and I think that's hopefully we're gonna learn more about that over the next few years. And then as far as hemifacial spasm, lateral spread, I think, has been one of the most important prognostic tools that we have, and I think we don't have a whole lot of them in neurosurgery, but the ability to see underlying lateral spread and see that disappear, and to also distribute between, the superior and inferior division, I think is actually very useful too. Sometimes I'll have a surgery where I think the decompression looks good, and our monitoring team will say, well, you only have a partial response to the lateral spread, for example. And then if you look deeper, or if you dissect deeper to the brainstem, you can actually see that there may be distal contact. Dissecting that out actually gets rid of the lateral spread. So for myself, I find it very useful, and I think it keeps your attention to really making sure you're treating the underlying physiologic compression. So, there's subtleties also in the monitoring paradigm. You can change some of the protocol with that as well. And there's a lot of research which I think has shown that if you do mentalis versus orbicularis, or if you do that versus oris, you can get a better projection. And this movement is antidromic, so you can actually start to really decipher the different lateral spread if you have better